and I'm looking forward to his talk.
So thank you very much for this kind invitation, Jeff. So first of all, I want to show which is the definition of non-syndromic aortic condition. So I looked carefully into the literature, and I was able to find only this paper, which has been published in 2016 in Circulation, which defined the non-syndromic aortic condition in three groups mainly. The familial thoracic aneurysm aortic dissection form, the familial thoracic aneurysm form, and of course the bicuspid valve with associated aneurysm into the ascending aorta. But there is another category which in some paper is mentioned, which is also the sporadic aortic disease of the aorta. So before digging into the need of screening in this population of patients, I think it's important that we underline the fact that outcomes definitely are related to the type of pathology, meaning aneurysm and acute aortic syndrome, the presentation of the aortic disease, and also the patient profile, including a category which often is not really considered, which is the modality of inheritance of the aortic disease. And this is important because these are the data we published 2 years ago with the UK Aortic Forum, which showed that the same operation performed in an active manner has a decent mortality, but when the same operation is performed in an emergent setting, the mortality can go up to 30%. Therefore, an early recognition and prompt surgery, I think, is of paramount importance. And of course, this can be done by a careful screening, including imaging and genetic test. However, while in the syndromic form, this early recognition is quite easy, in the non-syndromic form, this is quite impossible. There are no pathognomic external features which can help to identify the patient to deserve screening. And if you look at the guidelines, these are the American, the European, the Japanese, and the Canadian, there is a somewhat chaotic indication for the non-syndromic form. I try to summarize the American, the European one, the American on the top, which show that theoretically you should subject to screening the first-degree relative of a patient with a non-syndromic form, and they use specific genetic marker which are mutuated from the syndromic form. But what about the follow-up? Only the European guidelines suggest that when you identify a low-risk patient, which is not clear to me what does it mean, you can subject this patient to a follow-up every 5 years. And this chaotic indication, I think, is also reflected in the normal approach to this patient. This, again, is a paper we published with the UK Aortic Forum 2 years ago, which showed that this lack of guidelines is reflected in the daily practice and results. You can see different treatment rates, even in England, even in each counties, which give also different mortality rates, not only in treated patients, but also in untreated patients. Therefore, the screening in non-syndromic aortic disease is affected by several biases. We don't know what kind of population we need to subject to screening. We don't know which test is the best, the genetic or imaging modality, the effectiveness of such program, the follow-up, and also we don't know the prevalence of non-syndromic aortic disease. So in order to overcome this problem, 2 years ago we started performing a larger systematic review with the aim to answer to some of these unsolved questions. First of all, the prevalence in each family of this patient affected by non-syndromic thoracic aortic disease. The screening needs only in first-degree relative, or we need to extend this screening in second-degree relative and third-degree relative. And the predictive accuracy of imaging and genetic test. And also we focus our attention in the baseline characteristic of sporadic and familial non-syndromic thoracic aortic disease. Of course, our systematic review was done accordingly to the PICOS criteria. And we analyzed more than 12,000 papers. So at the end of this careful scrutiny, we were able to identify only 53 papers. And interestingly, even in literature, it's not clear what kind of screening you need to do. 49% of these papers, they just perform a genetic screening, which clearly is able to identify the genetic carriers in the family, but doesn't give you any idea about the size of the aorta or the shape of the aorta or an underlying aortic disease. 40 paper, they adopted genetic test accompanied by imaging modalities, and all 11 paper use only transthoracic echo or CT scan as preferring imaging modality. So we look into each paper and we analyze each pedigree which was presented. For the first time, we analyze in each pedigree the first degree relative in terms of aortic disease genetic mutation, the second degree relative, and also the third degree relative. We also collect other important demographic variables, like the number of the family member, the number of probands, the penetrance, the modality of inheritance, the type of screening. I think it doesn't work anymore. Can you go to the following slide, please? Yes, we also collect the rate of aneurysm in each family, the rate of aortic dissection with a special reference to the age of dissection. But also, we identify that from 6 to 10% of the family member, they can be affected by specific physical feature. We can help you to identify patients who probably deserve straight away a screening program and even a prompt surgery, which give you an idea that the non-syndromic form, they have a sort of overlap characteristic with the syndromic form. Of course, based on our systematic review, we were able to confirm that already published in the way that sporadic form, they tend to appear later. But also, and I think this is very important, the aortic diameter is not a marker of risk of dissection, because part of this patient, they dissect even when the aortic diameter is below 4 centimeters. So this, I think, is a very interesting picture. So we analyze first degree relative, second degree relative, third degree relative. And what we found is that not only the first degree relative are affected by an underlying aortic disease, but also the second degree relative, 24%, and even 15% of the third degree relative. So just this picture make you aware that there is something wrong in the current guidelines. And if you see the gray column, you can see that even 24% of the patient in each family is not even screened because of the patient were not reachable, or because the patient died, or because they refused screening. So we look into the genetic mutation of this non-syndromic form. So we were able to identify 15 genes which strictly correlate with the non-syndromic form, and 3 loci with not recognized gene. So this is just a summary with the location of the gene to the specific chromosome. And we are able also to do a gene-gene network analysis, which show, it's a very complex picture, but we show that part of this gene are commonly encountered in syndromic form. So just based on this picture, the question is why we cannot use the guidelines for syndromic form and expand this guideline to the non-syndromic form. This is a nomogram that we derive from the published paper we analyze. And as you can see here, you can correlate the genetic mutation with the age at risk for dissection with the baseline aortic diameter. And you can see on the right that these 2 genes that in the guidelines were supposed to be related to high risk of dissection actually is not the case. Because as you can see, this patient tend to dissect when the aorta is around 6 centimeters. So the risk of dissection is very low. So in conclusion, so the current guidelines did not capture the real need of screening in non-syndromic form. There is a male preponderance, and 30% of the patient in each family present an underlying aortic disease. There is an incomplete penetrance, which means that sometimes you see the patient affected after 1 generation. And I didn't show the data, but the sporadic form, they are related to de novo mutation, which means that there is no need to screen the second degree relative, but the first degree relative, yes. Certainly there are limitations because all the studies were based on a small patient population, normally single families. There are no data on follow-up, which should be the best follow-up. There is no data on effectiveness on a large screening program. But what we can certainly conclude, just based on this systematic review, is that in the familial forms of non-syndromic aortic disease, the screening should be extended to the first degree, second degree, and even third degree. In the sporadic form, the screening should be extended to the first degree relative. But this is a picture which has been slightly modified from John Eleftheriades, which was referred initially to the syndromic form. So we cannot extend our treatment, our indication, only based on the size of the aorta, but we need to incorporate the genetic mutation. Of course, this is a simplistic picture, but in the non-syndromic form, I think the screening pathway should take into account the familial form or the sporadic form, the type of population, first degree relative, second degree relative in the familial form, and first degree relative in the sporadic one. Of course, the aortic size is important, but I think the genetic mutation is the most important element in order to understand if the patient deserves a prophylactic surgery, even if the diameter doesn't reach the normal cutoff, 5 or 5.5 centimeter, which is shown in the current guidelines, and patients with specific genes, these genes, so probably they deserve more attention than other patients. Thank you.